Hello and welcome, everyone. We're thrilled you're here. My name is Dr. Sarah Allen. I'm a board certified internal medicine physician, and today I'm talking about all things women's health. We're going to start with the foundations of menopause because I want to set the foundation and the stage for the rest of our women's health series. It's imperative that you understand definitions, physiology, and timing because this is critical to deliver safe and effective patient care. It's not just about knowing the textbook stages, it's about translating that knowledge into real conversations with patients who are trusting you with their health and well being. And if you're a patient, we're glad you're here to learn more about what may be going on with your body. But we are always happy to answer any questions, and your healthcare provider should always be happy to answer any questions that you may have about your health. When I walk into a menopause discussion or a perimenopause discussion with a patient, I always want to be crystal clear in my definitions, and so should we as healthcare providers. We're going to review these terms so that no matter the patient's age or presentation, you can confidently place them on a reproductive timeline. We'll cover what the terms mean, why they matter clinically. We're going to revisit the hypothalamic pituitary axis. And even if you've been in practice for years, this quick refresher will help to connect symptoms to physiology in real time. Finally, I'm going to walk you through the timing hypothesis, why it changes how we counsel patients about starting hormonal therapy now. And the key takeaway is without all of this information, you can't make sound treatment decisions for your patients without accurate staging and an understanding of the hormonal shifts that are driving these symptoms. So, very important. We're going to talk about all of that today. So, why does menopause really matter and what's the scope of the problem? So, for me, I am an internal medicine physician. I mentioned this when I first started, and I distinctly remember seeing patients in my clinic who would come in and they would say, I just don't feel like myself anymore. And at the time, really all we had to offer these patients was an SSRI like Lexapro, Celexa, Zoloft, other medications like that, selective serotonin reuptake inhibitors. But we now know that there may be an underlying physiologic cause for women who feel this way. We're going to talk through all of that. But the scope of the problem is 47 million women enter menopause annually. That is a lot of women, and only 6% of those women are receiving appropriate guidance and treatment. More than that, half of women who are age 30 to 35 are experiencing symptoms of perimenopause. Their bodies are starting to change and they don't often know what's going on. And I tell my patients all the time, think about how much you had going on in adolescence. Menopause is the same way. And it's very important that we take care of our patients. Many physicians have not been able to be adequately trained in how to treat patients because the research and care is emerging so rapidly that oftentimes it's difficult to keep up when you have a busy clinic and you are taking care of patients every day. It's important that we know and review definitions anytime we see a patient because the most important thing is mislabeling perimenopause as menopause or vice versa can lead to inappropriate treatment in these patients. And it's important that you distinguish as such. Your dosing is different, your medications could be a little different. So it's important to note. Menopause is a point in time. It is defined as the absence of a menstrual period for 12 months or more in a female. And so the average age is 51, but that age could range anywhere from 40 to 58. It could be surgically induced, so the patient has had the ovaries removed, or other causes like chemotherapy or radiation. Perimenopause is the time where your hormones are wildly fluctuating before menopause, and this could actually occur up to 10 years before the last menstrual cycle. So, if we only go by the definition of menopause, we are missing many patients who are experiencing hormonal irregularities that are very important to help guide them through because it makes them feel so different. Early menopause occurs when you have menopause before the age of 45, and premature ovarian or primary ovarian insufficiency is when you have ovarian changes before the age of 40. And this is very important to distinguish. Just because you may be experiencing symptoms of perimenopause does not mean that you have primary ovarian insufficiency, and this is important to note. But in order to understand what happens in menopause, we first have to understand normal physiology. Remember, your hypothalamus typically secretes gonadotrophic releasing hormone, and that goes to your pituitary gland and stimulates the pituitary gland to release FSH or follicle stimulating hormone and LH luteinizing hormone. So, in essence, FSH is released from your pituitary gland. That stimulates your ovarian follicles to develop, and one follicle becomes that dominant trigger for estrogen release. That thickens the uterine lining for egg implantation. And then estrogen triggers luteinizing hormone release from the pituitary gland, stimulating the follicle to open up and release that egg. And so estrogen is your dominant hormone during this phase. Once that egg is released, you have a follicle, which is then called the corpus luteum, and that releases progesterone, which becomes the dominant hormone after ovulation. Remember that. And you even see it here as the uterine lining thickens without implantation. So there's no egg that's going to implant into that lining to then be fertilized. Estrogen and progesterone fall off dramatically. The uterine lining sheds, and that's what we know as a menstrual period. As we lose those ovarian follicles over time, the remaining follicles become less responsive to follicle stimulating hormone, FSH, and luteinizing hormone, or LH. Your estrogen levels begin to drop, and in response, the pituitary gland is ramping up production of FSH and LH because it's saying, come on, ovaries, let's develop an egg and let's spit it out so that it can implant into the lining. This is a classic negative feedback loop. But your estrogen is declining because you're beginning to be in perimenopause and it's all out of whack. And these inconsistency in hormone levels lead to luteal out of phase events or loop events. So what's really important here is in the late transition of perimenopause, cycles can be long, ovulation is irregular, but you can still conceive. And that's why you may have heard of patients, or if you're a patient, you may have friends who have been particularly fertile in this period, and it's important to remember that. In order to understand what's happening during menopause, you have to understand that there are three predominant types of estrogen in your body, and these estrogens shift over time. So you don't have the same amount of all of the estrogens at all of the times in your life. Estrone is typically known as E1 here at the top, and it is the postmenopausal dominant form that is converted in your fatty tissue. So think about it. This is your most predominant estrogen after you are in menopause. Estradiol is dominant in perimenopause, and it is the most potent form, and it originates from the ovaries. It makes sense that as your ovaries lose function during menopause, estradiol becomes less prevalent. And the third form is estriol, or E3. It's the weakest form, but it provides protection for the vaginal and the GU mucosa. Interestingly, if you have a patient who is a little overweight, obesity is associated with increased aromatization of estrone and estradiol levels. So just remember, fat leads to aromatization of androgens and estrogens, and this could increase risk of certain hormone sensitive cancers like breast and endometrial. So, why are so many people concerned about hormone therapy? Well, the Women's Health Initiative was a large research study that took place in 2002. It looked at over 16,000 women to determine the effects of combination estrogen and progestin therapy versus placebo. Patients who were enrolled in this were healthy overall, and they had an intact uterus. only 8% of those, or less than 8% of those, had a reported history of cardiovascular disease when they started. The average age of patients in this study was 63.3 years. If you think about it, we just talked about the fact that the average age of menopause is 51. The age of this patient population was well past the age of women in menopause or developing menopause at that point in time. So, a few key things to note: they only looked at oral medications and only studied conjugated equine estrogen and medroxyprogesterone acetate. They didn't really look at any other formulations there. So they stopped the study early because they found an increase in heart disease, in stroke, in thromboembolism, so blood clots, and breast cancer. And these were not offset by the reduction that they actually got in fractures, bony fractures from osteoporosis, or colorectal cancer. So this looked very negative when they initially looked at the data, and patients were scared overnight. And so were providers. But we know through further studies that hormone replacement therapy can actually be beneficial in patients who are 60, less than 60 years of age, who start hormone therapy within 10 years of menopause. That is why the timing hypothesis is so important. And the key here is to individualize therapy and determine if you are an appropriate candidate for therapy, and if you are, which therapies are most appropriate for you based on your history taking. So we're going to keep talking about this all throughout our Women's Health series. And what we know now is that hormone therapy, when individualized, can be of benefit to women for so many reasons. It can decrease vasomotor symptoms. It can give you a steady state of hormones, whereas your hormones in perimenopause are fluctuating. Hormone replacement can actually level you out, and it can decrease your risk of heart disease later in life, of cognitive changes. It can improve sleep. It can improve mood when delivered appropriately and when prescribed by the appropriate healthcare provider. But it's important that we perform an individual risk assessment and stratification on each patient. So, after our first session, here's what I want to leave you with. In women who are over 45 with classic symptoms and cycle changes, perimenopause and menopause are the clinical diagnosis, and treatment is based on those symptoms. You actually don't need labs. They may not even guide it because our treatment is going to be based on symptoms. Typically, I will only check these labs if the diagnosis is unclear or if I need stratification for your heart risk later in life. Body composition here matters. If you have more adipose tissue or have obesity, that means that you typically have more estrogen, and that can affect your symptoms, your cancer risk profiles, all the things. The Women's Health Initiative created an unnecessary bias in opposition to hormone replacement therapy. It's important that your provider matches counseling, treatment to your physiology, and timing and your priorities.